Hey, everybody. I appreciate you joining me today. This is an incredibly important topic for me and for a lot of people out there, and that's sudden cardiac arrest in sport. This is something with a relatively low incidence rate, but each case is exceedingly tragic, and I think it's something that it's important that we talk about, reflect on what we're doing, and make sure that we're doing everything that we can to help prevent it. And my guest is here, so I think she's here. Bring her in. I know Dr. Green had you there, Dr. Green?
I am. Can you hear me?
I can hear you. I can't see you, though.
I know. How do I get on the video? You know I don't know how to do this.
I wish I could help. I'm not
Let's
sure
see.
why it's not popping up.
Hold on.
All right, just a little bit of a technical difficulty there. Sorry about that. She should be right back. Do the invite for her again. But yeah, like I said, we're going to be doing. Oh, I see her. There she is.
Okay.
How are we doing?
Good. How are you?
Good. So as I was just kind of saying, that this is a really important topic, I feel, talking about sudden cardiac arrest in sport. Even though it's something that, if you look at the incidence rates for as many sports and as many people are playing sports, the incidence rates are relatively low, but you can't overlook how tragic every single case is that occurs. So as athletic trainers and as physicians with a sports medicine team, are we doing enough during our screening process? Is there more that we can do? Are there things that we can do better to either respond to these events or to help identify some pathologies before they become disastrous? So with us today is Dr. Alysia Green. Thank you, Dr. Green, for joining us.
Thank you for having me.
Absolutely. Now we'll do a quick bio here, relatively quick. I know. But Dr. Green was born and raised in Michigan. She's a proud alumna of the University of Michigan. And after she received her BA in biology, she went on to attend Wayne State School of Medicine in Detroit, where she received her Doctor of Medicine. Dr. Green completed her residency in family medicine at Case University Hospitals of Cleveland, and then did a sports medicine fellowship at Michigan State. So she did both Michigan and Michigan State. I'm curious. Upon completion of her fellowship, Dr. Green joined the Department of Family Medicine at Boston University and Boston Medical Center in August of 2007. For the last 14 years, Dr. Green has worked as an assistant professor of family medicine and primary care sports medicine at Boston University, and she spent the last 2 years as a head team physician at BU. Outside of all of those responsibilities, she also has worked with national governing bodies of the U.S. national teams and has traveled to provide medical coverage at many national and world championships. In 2018, she was also chosen to be a staff physician at the Winter Olympics by the U.S. Olympic and Paralympic Committee. She has recently left BU, much to everybody's dismay, but she's back home in Michigan now, and I'm excited to see what's next for you. So like I said, thanks again for joining us. I know you got a lot going on, but I want to ask you a few questions, get your perspective a little bit more on things.
Absolutely.
Did I miss anything in your bio? We get everything okay?
No, you got everything.
All right. So now, let's just call it, in your perfect scenario.
Yeah.
What does your preference for a pre-participation cardiac screening look like? What types of things does it involve?
Okay. So it starts with any personal and family history. And the American Heart Association actually has a 14-point screening guideline question that has been used in conjunction with the American Academy of Pediatrics, American Academy of Family Physicians, etc., that I think is excellent as far as knowing what questions to ask in the history. Because a lot of what we do in medicine, regardless of whether it's within athletics or doing inpatient medicine, history is the most important thing. The patient is trying to tell you something from the history. So knowing both that personal and family history and kind of standardizing some screening questions I think is the number one thing, followed by the physical examination, of course. And that doesn't just involve a good cardiac exam, although obviously that is of importance, being able to pick up any murmurs or listening for any pre-articular contractions, contractions or pre-ventricular contractions. But there's other things on physical examinations for other syndromes, such as Marfan syndrome, which you can also see in that physical examination. And then taking feeling for pulses, taking blood pressure, et cetera. And then I know we'll be speaking about this a lot, but I also do like the addition of an ECG to the pre-participation screen, and not just for our Division I or high-level competitive athletes. I do think that the athletic population, including our younger athletes in high school, an ECG is can be an appropriate tool to use. Not the only thing, but I do think that it is an important part of our cardiac screening process.
Yeah, and I think we'll circle back on the ECG in a little bit because I think it's kind of a hotly debated topic right
Absolutely.
now. But I think based off of your answer and things like that, I think I know where we're going with this. But for programs that kind of lack the resources to implement something like an ECG or other diagnostic tools, you think the most important steps to prioritize are the standardized questions, right? To get that family and personal history.
Yes, and of course the physical examination, but the history, you can really pull a lot out of the personal and as well as the family history. Some of the causes that can lead to sudden cardiac arrest or sudden cardiac death can be genetic. Not all of them, but they can have a genetic cause. And so you'll often find perhaps someone's sibling had an event. Someone's father has an AED placed. Why is that in? Now, a lot of times it is difficult. It can be difficult to get that family history because young adults don't necessarily know what the cause is or why that was placed or what the cardiac history is. But just kind of picking up on some of those things. Anyone who has any premature death in the family. These are all kinds of, I think, important questions. And then, of course, their history. I mean, I can't tell you how many times I've tried to, you've talked to an athlete and they're like, oh, yes, I get chest pain when I exercise. And they just like think, yeah, of course I do. That's normal. So I think, even being able to piece out some of that is some of these symptoms that they're getting that they think are fine. Shortness of breath, are they having heart palpitations, any sort of decrease in their exercise capacity. All of these things could be leading us towards thinking of some sort of cardiac pathology. That being said, I also think there are three other things that I think are important that can be implemented and should be implemented, and that don't have anything to do with an EKG. And I do think the first thing, and we could talk about this for a whole nother couple of hours, but for me, the number one other thing is that you need to have certified athletic trainers on your staff. I feel very, very strongly that every single high school in the United States of America should have an athletic trainer. There's no reason we should be having athletics without a certified athletic trainer. And so I think that is very important because as healthcare professionals, the certified athletic trainer can help with some of these things. Coaches are not, this is not a coach's job. And frankly, it's not the job of the school nurse. And there's other primary care professionals who might not know as much to do the cardiac screening for the or how thorough should be for a pre-participation screen. So, and we also have to remember that the pre-participation screen is not a physical examination for an athlete. So that does not that should not be used in place of their normal yearly physical examination. That can include some other things. But I think that when we really focus on that pre-participation cardiac screening, I think it involves a little bit more than just a general physical examination. The other thing I think that's very important is having an emergency action plan. That's going to be one of the most important things. And not just having it, you have to review it. You have to practice it, and you have to discuss it. One of the things that I really enjoyed and that I thought was very important at multiple different levels, including when I was at BU and when I would work with the national governing bodies, is before every competition, we would review the emergency action plan as an entire group of practitioners and medical professionals who are, on the floor could be involved, and whether it was a musculoskeletal accident or some sort of cardiac event. So having and developing and implementing, knowing how to implement your emergency action plan is also very important. And then the last thing, an AED.
Yeah.
You got to have access to the AED.
Right. And we'll certainly touch on that more, but yeah, being able to have more positive outcomes when these events do occur, because even with the most perfect screening process, we're not going to get everything.
That's right.
And you've always been such an advocate for the profession of athletic trainers. So I just want to take a second to thank you for everything that you've done, just promoting our profession as well. It's very important. So thank you.
You're welcome, of course.
And I think from an AT side of things, what's really difficult in a lot of settings, when I was in the secondary school setting and when I was in the setting, student athletes bring your paper, in an ideal world, bring you their paperwork before their but their pre-participation physical that they got from, whether it's their primary care physician or it almost seems like they're trying to check a box. So maybe they went to an urgent care. Maybe they went to maybe they went somewhere. And what is their screening process? We don't know if they're using the American Heart Association checklist. We don't know what type of questions they're asking, right? So really knowing what questions were asked is helpful. And being able to implement that into our pre-participation screening process when they come in. Even if it's the 5th time that they've heard these questions, I think we need to ask them every single time for every screening process and every single year, because things can change, especially in developing, 16, 17 to 22-year-old that's, highly involved in athletics.
Right.
Things can change. So, being able to ask those questions every single year, I think is important for us, and standardizing it somehow. I don't know how that happens. That's a much larger issue, but
exactly.
Where are they going for their yearly physical, and what types of questions are being asked? So it sounds like you're a proponent of the EKG or ECG prior to every year, right? I guess I just want to hear your rationale first, and then we'll kind of go over some of the sticking points for other people.
Yeah, I think that, I think I've really been thinking about this probably for over a decade. I know, you're aware, Josh, that this has been something that has been discussed for many, many years. And just that even that first year coming out of fellowship, that group out of Italy, they published their findings. And yes, they have a different population. Their causes of sudden cardiac death are a little bit different than what we have found here in the United States. But they did find that the addition of the ECG in the pre-participation screen really did decrease decrease mortality in their young competitive athletes from sudden cardiac arrest or sudden cardiac death. I do think that physicians and other medical professionals, this shouldn't necessarily be across the board, and I do understand there is a risk for some false positives, right? That leads to anything from holding athletes out unnecessarily as you continue your cardiac workup. Obviously, anxiety for not only that athlete, but their parent. And I've seen this when we have actually had some abnormal screening ECGs, where in some cases we have picked up something. And then in other cases, it ended up being what we call the normal athletic heart, right? So, but I as a tool, I do think it is important. I do think it can decrease our mortality in athletes. I do think that we can pick up perhaps some athletes that have an underlying cardiac issue. And so I do think, if available, it is something that should be used within the pre-participation cardiac screening. That being said, I also do think that there needs to be availability to physicians, whether that's a cardiologist or sports cardiologist, whomever is reading your ECGs, needs to really know how to read an ECG, particularly in the athletic heart, because as we know, there are some abnormalities, both related to gender and ethnicity, that could look abnormal on the ECG, but are actually normal findings in an athletic heart. So I am a proponent of the use. I think maybe some of that is part of it, maybe my training. I was able to train within a Power 5 conference and work at a large Division I university. And so I do understand that there are going to be limitations for others. But again, as I said, with the history and physical exam, plus I think the ECG, I do think that's a fully and complete cardiac screening for our athletic population.
Yeah, and I think one of the biggest arguments has always been, like you said, the false positives leading to follow-ups. They can be costly.
Yes.
Where does that payment, come in, especially in a university setting? Always going to be who's paying for this, right?
Yes.
Down to it. But there are different screening criteria for the ECGs, right? There's different ways that you can read it to help limit some of these false positives, to rule out, okay, this is an ECG, this is reading like an athletic heart, right? Like Dresner and his group in Seattle have gone through for what, 2010, I think was their first Seattle.
Yes.
Where they've kind of come up with a criteria for these are how the athletic ECGs should be read.
Yeah.
And I don't know how many physicians are trained on that. Do you know, is it a pretty regular occurrence, or is it relatively rare?
So I think that obviously those of us who do sports medicine get the training within our fellowship. I can tell you that at least when I trained, and it sounds really crazy to say almost 20 years ago when I was an intern, no, we would not have gotten specific training on the Seattle criteria in particular, which we now kind of use across the board within the sports medicine community. And so that is, an issue. I don't know how many pediatricians are trained, well, number one, on just ECGs alone. And then again, on the Seattle criteria and the fact that we can see some of these abnormalities, such as a right bundle branch block in an athletic patient is actually a normal variant. Whereas again, a left bundle branch block in really anyone is abnormal and needs further evaluation. So that is an issue. And as you said, even just going back to what you were saying about, we don't know where these kids are getting these pre-participation screens. Are they just going to an urgent care? And like you said, they just check the box off, you know, they do some blood pressure and listen to their heart. And they probably, I shouldn't say this, I don't know, but I doubt they're doing a 14 question cardiac screen at the urgent care. So that is something that could definitely increase that false positive rate if you're just asking someone who is not trained. Dr. Dresner and his group and some other sports cardiologists have actually discussed being able to develop groups regionally throughout the country where you could establish this is a group that could read your ECGs, that knows about the athletic heart. And so something that you could maybe establish in a regional perspective. But yes, knowing how to read is decreases it. And once they were able to kind of, when was that, in 2010, 2015, when they kind of had that international meeting in Seattle, and kind of just came up with this criteria, it decreased the false positive rates from about 25% false positives prior to this establishing this kind of Seattle criteria that we use, to 5 to 6%. So when you get someone who knows what the criteria is for the athletic population, it does decrease that risk of false positives, and then kind of decreasing the fact that you're going to be leading possibility of causing other costs.
Yeah, and I know that they continue to study and review what they're, and it just always seems like they're improving just over and over what they're looking at for the Seattle criteria, because they're always kind of updating it a little bit.
Yes.
Years. Similar to the concussion summits, I think.
Absolutely.
Years too. So I guess just in basic terms, what types of things, if we're running ECGs on our student athletes as a screening tool, what types of things is it able to kind of rule in and rule out? And things that it's not going to identify.
So the things that it really can identify are arrhythmias, so any sort of an abnormal heart rhythm, which could lead you to thinking, okay, what is the cause of said arrhythmia? Is it a structural cause to the heart, or is it something electrical that we're dealing with? Obviously, it can rule in a myocardial infarction, which we're not going to necessarily see in a young athletic heart. Any sort of ischemia, so any sort of abnormal blood supply, and then it can rule in hypertrophy, or thickening of that heart muscular wall, which we can see in patients who have, for example, hypertrophic cardiomyopathy. So those are kind of the big things that it can rule in. That being said, obviously it's such a small, it's so quick, right? If we could be missing people that actually do have a structural cause and it's not showing up on the ECG. So as you said, there's nothing that is 100% and going to pick up everything. But as I said, I do think the addition with the ECG in coordination with our history and physical examination, I think does give us the best chance of being able to diagnose any sort of cardiac pathology that could be needs further workup in our athletic patients.
Yeah. So, and just like you touched on earlier, and you touched on it again there, even with the perfect screening process, we're not going to find everything, right? And side story, early in my career, I actually had a student athlete go during the off season, like summertime, go to get screened to have LASIK done. and they noticed something with the connective tissue in his cornea and said, you may have Marfan's. Surgery. Let's get for some ultrasound, some stress echoes and stuff. He ended up being disqualified, and he was a junior. He had played competitive basketball for 2 years, and that was just something that I always went back to, and my career on. It's just like the craziest way to find it.
Right.
Anyway, with all of that's why, like you said, it's important to have the emergency action plan in place, thoroughly thought out, well versed, and you should bring EMS, everybody in at least annually to really run through a lot of different things, right? I guess in all of your sports medicine settings, what was kind of your biggest takeaway when you would get together and rehearse it? What was maybe your biggest takeaway of doing that rehearsal, right? Something that you might have learned or thought of that you might not have otherwise if you didn't do the rehearsal?
Well, I just think that it really led to, when there was an emergency, unfortunately, the seamless execution of how we evaluated the athlete, removed them from play, and kind of took care of everything. This isn't a cardiac injury, but one of my bigger injuries early on was actually an open ankle dislocation when I was covering a gymnastics competition. And I was not expecting an open ankle dislocation on the floor. And I just remember every single person who was on the floor, from all the athletic trainers to every physician in every corner to the EMS who was present on competition day, we met before every single session and went over what we would do, what happens if someone gets injured on the floor, because to complicate this situation, it was also live on national television. So there were some other things that we had to talk about, including the evaluation and being able to get the athletes safely off. And I just remember this because it was live on national television. I just remember thinking, oh my gosh, we've been up here forever. And you look calm, but, again, I was not expecting the injury. I could see it was a dislocation, but when I saw that it was open, it was kind of like, oh my goodness. And I just remember not only hearing from the patient's athlete, but from the patient's parents, the athlete's parents, but from others, she was an international athlete, so from her country and her medical team, how seamlessly it appeared that we were able to handle this emergency. And that was because every single person on the floor involved in that emergency knew what they were supposed to do, how it would go, where the transfer was. This was one event. The other 3 events were still going on while we were dealing with this emergency. So even those teams at that event, knowing while we would want to help, we also need to stay in our event. So just all of that stuff. And so I think that there is something about repetition, right? And I used to think, I know probably some of these people who have been here 3 and 4 sessions are like, we're doing this again? Yes, we're doing it again. Because while you have heard my spiel 3 or 4 times, the person who just is coming in for their first session hasn't. We also, as a group, have not all worked together, even if you've heard it multiple times. So that is what I think is important, because then it just becomes natural to you. There isn't a panic, even if you are inside feeling a little bit of anxiety, because I can imagine, thank goodness I've not had a cardiac event. And I know that it is rare, but obviously when it does occur, we're worried about more than just a musculoskeletal injury. We're worried about possible death. So that could obviously be anxiety provoking, but knowing and having the confidence that you have, not just you, but everyone who's involved in the team has reviewed that emergency action plan and can execute it seamlessly, I think is really, really important. So being able to get everyone together, as you said, Josh, I think once like bringing in the EMS and everyone who could be involved. But I also advocate for a pregame meeting of the people who are actually at the event, including EMS if they are there, or, we would include the police officer who would be helping get the EMS up or directing. Even if you have athletic training students there, I had medical students sometimes who cover things with me. So everyone who would be involved in any sort of medical emergency, I think before every single game match should have just a meeting. And it doesn't have to be, a long meeting. Everyone introduce themselves and kind of establish who would do what if said emergency took place.
Yeah, absolutely. Absolutely. It's incredibly important. One thing that I always took away from those meetings was figuring out the role delineation. I've had numerous team physicians, like, I don't want a high level role because I don't do that a lot. I'm not taking the head at C-spine. No. I'm not PR. Like, yes, I'm trained in all of that. I have had exposure to it, but it's not something that I'm harping on all the time. So that should not be my role. So,
right.
That's always something to key in on when writing and thinking through and reviewing your emergency action plans is who's doing what.
Yes.
Now, changing gears a little bit, because the times that we're in right now with COVID and that being something that we need to be much more aware of, long COVID not really being super understood. Is there a threshold now of requiring ECG or higher level cardiac testing after a COVID diagnosis for return to play?
Well, I was reading up on this a little bit more because in the last 2 years, I think that there has obviously been a lot of change to the recommendations in general. And everyone kind of was able to establish their own plan post-COVID, depending on what kind of resources you have. So, some of the Power 5 conferences early on, they were able to get an ECG, an echo, perhaps a cardiac MRI on all of their, positive, post-positive COVID athletes prior to returning them to returning them to sport, regardless of their symptomology. And I would say there's a JAMA article from last year where they kind of spoke about cardiac MRI would be great, right? Everyone can't get a cardiac MRI. That's just not going to happen. So some of the recommendations, again, mostly I do think that getting away from the patients who were truly asymptomatic. And so then there becomes another discussion about, well, what is asymptomatic? Like, I had a cough and a runny nose, but I only had it for 1 day. Is that symptoms? But the ones who had either mild to no symptoms versus the moderate to severe, or if they were hospitalized. I do think the moderate to severe and the hospitalized patients, I would, they would recommend kind of like the post-COVID ECG. Some people are getting labs, including checking some troponins, and some are recommending that you even get the echo on those patients. I do think on the patients who had moderate to severe symptoms and anyone who's hospitalized, I do think a post-COVID ECG is appropriate, particularly if you have a standard ECG from their pre-participation screens at any point. to kind of compare it to actually see if there was any change to pick up on. But I also think that it's reasonable to also start the return and see if there's any symptoms, right? The patients that I saw that did get post-COVID myocarditis or pericarditis, very early on in the return, simply could not return. They got cardiac symptoms. They were having chest pain with exercise, period.
Yeah.
Shortness of breath. Some of them were having chest pain, at rest. They could not progress. And that really triggered the full cardiac workup, including the echoes with the labs and and some got cardiac MRIs, and some just based on echo lab and history were diagnosed clinically with myocarditis or pericarditis. And so again, that goes back to the athlete giving you a history of what their symptoms are. The ECGs often will be normal, even with a myocarditis or pericarditis. So again, you have to go off that history. And if you do happen to hear a rub or a murmur on physical examination, then of course that as well. But what I did, as I said, what I found and what we saw really was, once the return started, the inability to exercise without getting cardiac symptoms, which is what really triggered the full cardiac workup. And did we have some that were getting symptoms and had a negative cardiac workup? Absolutely, we did. But we also picked up some of the myocarditis and pericarditis as well, which clearly changes the return to play and treatment options at that point.
Okay. One more question for you, just because I feel like I would be remiss if I didn't ask this, because I still have people ask me, whether it's former patients, family members, things like that, that have concerns about the COVID vaccine with the causing myocarditis. I mean, are the numbers bearing out that this is something to worry about, or is this just something else entirely?
I would say the numbers are not bearing out that this is something to worry about. The CDC did publish last year, there's about 1,000 cases of patients getting a myocarditis or pericarditis post vaccination with the Pfizer or Moderna. That's out of millions of people who have been vaccinated. And the cases that did happen, I can say they were in younger people, younger adults, males more than females. But they were also very mild cases, and they resolved in their own regard, causing no, at the time that they didn't publish any long-term effects that was noted. But again, 1,000 out of millions of people who have been vaccinated, the risk is very low versus the benefits of getting the vaccination. So yes, there have been some documented cases. But again, the risk in general is very, very low of the vaccine actually causing the myocarditis or pericarditis.
Okay. Well, as I've said, I really appreciate you taking the time. I know you are just uprooted and moved back. Left stuff in boxes everywhere. So
yes.
I always love speaking with you and catching up. I know it's been far too long since we've done this. So, and again, thank you for the advocacy for the AT profession as a whole.
Of course.
Very appreciated.
Yes.
And
thank
more
you for having me.
Anytime. So I'll let you go. Thank you again. And we'll talk to you soon.
Yes. Take care. Thanks, Josh.
Thank you, Alysia. Bye-bye.
Bye-bye.